series, our virtual innovative discovery series. So we are delighted to have Dr. Justin Martello, who is a neurologist expert in movement disorder at ChristianaCare, giving us a talk about Parkinson's disease. But before I introduce him, let me mention some housekeeping issues. So we will continue extending CME credits for our ID series presentations and all our tech talks. We will distribute the information via email to those that registered for today's event. If you did not register prior to today's talk, you can still obtain CME code information from Lisa Maturo at ChristianaCare. Her email address is lisa.m.maturo@christianacare.org. Our next ADI series, it seems that we don't have anything during the summer, so our next one will be September 18th, and that will be Dr. Greg Dobler from University of Delaware, and Dr. Dobler did a lot of work related to COVID-19 predictions. And our next tech talk, which is in fact on July 9th, so next week? No, the week after that. So do not miss the next tech talk. Is Dr. Yong Chen from University of Pennsylvania, who will talk about doing statistical analysis using EHR data. So that will be also very exciting, and our tech talks are on Thursdays. So again, I'm really delighted to have Dr. Martello, who is a Parkinson's disease expert at ChristianaCare, as well as an expert in quality and safety improvement science. Dr. Martello obtained his MD from University of Maryland School of Medicine in Baltimore. He did a neurology residency at University of Maryland Medical Center also, and where he also became neurology chief resident. He did a fellowship in movement disorder at University of Maryland Medical Center. He is currently a very active member of the American Academy of Neurology, where among many other activities, he is the chair of the Movement Disorders Quality Measures Workgroup methodology. So, and he is also a very popular speaker. So I'm really delighted, and we are honored to have Dr. Martello here today with us. Thank you so much.
Thank you for that nice introduction, Claudine. So today we're going to be talking about Parkinson's disease, specifically when it comes to subtypes and etiologies, or at least the theories behind the etiology of Parkinson's disease. I don't have any relevant disclosures today for this talk, because I won't be talking about any medications or things like that. But these are our objectives. So we're going to kind of catch everyone up to current data behind Parkinson's disease, not only epidemiology, brief pathophysiology behind Parkinson's, what is Parkinson's, going over the typical symptoms, and then we'll go into how the subtypes play a role in the picture of Parkinson's disease, again, about theories of why Parkinson's happens. Some are theories, some are kind of more known, information risk factors in regards to that. And then, why there are some limitations when it comes to kind of furthering our knowledge behind these things, because obviously Parkinson's has been around for quite some time. I mean, it was in, the early 1800s where James Parkinson first described, just sitting in a park chair, a park bench, his first witness people just, walking through the park with Parkinson's disease. So over the past 200 years, we still have, unfortunately, a lot left to know about this. So briefly, Parkinson's is a neurodegenerative disease. It involves one of the main players in Parkinson's is you have a loss of dopamine-producing cells in this kind of area of the brain called the substantia nigra. I'll show you a gross picture of what that looks like, but and really this translates to a lot of motor symptoms, and we'll talk about what they are specifically, but also a lot of non-motor symptoms as well, which I think is important. And again, I'll illustrate that in this slide in a little bit as far as what Parkinson's patients really experience. And to be honest, Parkinson's really affects every organ of the body, even the skin. It can elevate the risk of melanoma. So it truly affects every organ of your body. So a lot goes on. April is Parkinson's Awareness Month. We were supposed to have a symposium, our first for Parkinson's, but it's going to be unfortunately postponed until next year, obviously. So, as far as what are the current data behind how often do we see Parkinson's? So, in general, Parkinson's can affect 1 to 2 people out of 1,000, but obviously the prevalence is higher with age, and so over 1% of the population over 60 can have Parkinson's or has been found to have Parkinson's, with an annual incidence 4 to 20 per 100,000. Nowadays, Parkinson's patients do have an average life expectancy, and that just is more goes with our current knowledge of treatment, the options for treatment, and the way we approach treatment, at least for symptoms, and the importance of exercise with delaying the progression. And then there was a 2017 Lewin Group study in coordination with the Michael J. Fox Foundation that really used up-to-date statistics to kind of explore how many Parkinson's patients are estimated to be in each state. And in Delaware, they estimated about 3,400 Parkinson's patients. Now, this is interesting and important because there was actually a 2011, so 6 years earlier, study from the University of Delaware that showed 2,000 Parkinson's patients. So in 6 years, we've gone up by about 70% in Parkinson's patients. And so obviously Delaware being a popular retirement state, that would make sense, in a number of ways. But just interesting that we're seeing obviously a lot more in the state. So this translates to about 1 million patients in the United States with Parkinson's, which is more than MS, multiple muscular dystrophy, and ALS combined. About 60,000 new Americans are diagnosed each year, about 10 million worldwide in total. The men to women ratio actually used to be a lot bigger than that. It was thought it was like predominantly men, like 3 or 4 to 1 ratio. That's come down over time. We don't necessarily know why that is. Was it just not recognized? Women didn't present, or just thought to be other things. So, but it's still more common in men, just not as much as what we had thought in the past. So just a kind of a mention about lingo. When we talk about Parkinson's disease, a lot of times you'll hear from other physicians, sometimes even the laity, that will talk about Parkinsonism. They are not synonymous terms. So Parkinsonism just refers to a group of symptoms that are pretty common in Parkinson's patients, like slowness of movements or bradykinesia. You have this typical cogwheel rigidity, resting tremor, balance problems. And so instead of listing them out for patients, we typically, or for other doctors, we just kind of group them all together and just say Parkinsonism in general. But you can have Parkinsonism for many different reasons. You can have them from medication side effects. You can have them from strokes, other diseases other than Parkinson's disease. Now, yes, most people with Parkinsonism are going to have Parkinson's disease, but we'll actually talk later about how it may be a part of normal aging as well. So we'll kind of talk about that. Now, I created this slide, and I really like to show it to illustrate kind of what Parkinson's patients go through, because as I said before, it definitely affects every part of your body almost. And when you see a Parkinson's patient, a lot of times everyone thinks tremor, problems with their walking, and a lot of people don't have those things, or might not have tremor. Or may look really, really good, and they appreciate that. Maybe they're working hard, they're taking their medications, but a lot of times, even though they look great, they actually are suffering from, symptoms internally, and so they actually don't feel like themselves. They don't feel really, really great. And why is that? So typically we talk, again, about the common motor symptoms, the slowness of movements, stiffness, tremors, but what else do they, or can they experience? So up to 30% of patients develop dementia with Parkinson's. The numbers may be higher when you're talking about mild cognitive impairment. Maybe up to 60 to 80% of patients will have some kind of cognitive impairment with this. Nightmares, vivid dreams can be very unsettling. Sleep issues in general, they just can't fall asleep at night. Their brains are too active. They have what's called REM sleep behavioral disorder. They kind of kick and punch in their sleep and act out their dreams. Apathy is a big issue, and this comes quite separately, or definitely can come quite separately than depression, in the sense that it's just they're not happy, they're not sad, they're just kind of there, and they just don't care. But depression and anxiety are up to 50% in patients with Parkinson's disease. Hallucinations, delusions, or what we call psychosis in general, obviously later in the disease, but definitely an issue. Vision changes, smelling changes. There's changes in your voice volume and slurred speech, drooling. There's a nasal drip that can come with Parkinson's, which is an odd symptom. Swallowing problems, obviously later in the disease. Blood pressure fluctuations, constipation, just the slowness of your whole GI system, including your stomach with gastroparesis, erectile dysfunction, urinary incontinence, fatigue, dystonia, which is kind of an abnormal muscle spasm, gait and balance impairment. So a lot. And this is not my only slide, but it kind of gives some of the main symptoms that they tend to have. There's much more than this that comes with it. So just recognize that a lot of this is, they're struggling with internally. Now, I highlight the constipation, the decreased sense of smell or anosmia, and the REM sleep behavioral disorder because these tend to be prodromal symptoms of Parkinson's disease. In fact, if you have REM sleep behavioral disorder, there's probably somewhere around an 80% chance that at some point in your life, depending on how long you live, that you will develop one of the what we call the synucleinopathies, which under that kind of broad heading is Parkinson's disease, multiple system atrophy, and Lewy body dementia. So your risks are really high for that. If you have two of the three or all three of these, the risk factor that you're going to develop one of these at some point goes up to like 98%. So it's almost guaranteed that if you have these symptoms that you're going to eventually develop one of these neurodegenerative conditions. As I said, much more things obviously can happen with Parkinson's. One of the first things that tend to be noticed by family members is you stop swinging one of your arms when you're walking. Patients tend to know that their handwriting starts to get smaller and more sloppier. They get more of this, what we call mass facies or hypomimia, where they just kind of have a blank expression on their look and they're just not as expressive with their facial movements. Shuffling gait, difficulty getting up from a chair tends to be something that patients know. They just feel weaker in general. We talked about the voice, freezing of gait, kind of where they get hesitations in their walking. Their feet kind of freeze to the floor is what we say. They get a flexed over posture, other kind of gait abnormalities and drooling. And because movement disorder specialists love videos, we're going to try out a video of a typical Parkinson's patient just to give you a sense of things. So she has the clear, asymmetric is what we see, so one side worse than the other. Resting tremor, almost called the pill rolling tremor at times. You can imagine her kind of rolling a pill between her fingers. With a little bit of both hands, but obviously it's worse on the left side there. Some patients do have a postural tremor. They tend to have a tremor with walking in their hands, so that tends to be something specific with Parkinson's patients. As you can see, she's kind of slow, not swinging her arms when she walks. And you can see her movements, they're kind of slow, choppy, hesitant, not that great in amplitude. And then you can see with your other side, she does it a little bit quicker. It's still affected, right? So she still has definitely both sides of her body affected, but maybe not as much so. Then you'll see with her legs, that side's okay. I mean, still some hesitation, slowness, and then definitely much slower with her left side. So when we talk about subtypes of Parkinson's, there has been studies over the years, kind of redefining this a little bit. But right now, what we see is that there's kind of this young onset Parkinson's disease patient. This tends to be not as common. These are the patients who are between the ages of 20 to 40 years old when they develop it. There's a late onset Parkinson's, and these are the typical what we see, over 60. Usually the mean onset of Parkinson's is is somewhere in the late 50s, early 60s. Then there's a tremor dominant, or in other words, mostly tremor-related Parkinson's we'll talk about. Then there's something called PIGID, or postural instability gait disturbance, a subtype of Parkinson's. This used to be referred a lot of the times as akinetic rigid subtype, or in other words, slow and stiff and really no tremor, just kind of the other two symptoms with Parkinson's. There definitely can be mixed, and not only this, but we have seen over the years that people who are necessarily in one of these subtypes can, over time, as they progress, develop into another subtype or have a mixed presentation. So it's not that you're a tremor dominant one and you always continue that. There are those patients, but there a lot of times you can start to developing a lot of the slowness and the rigidity and have a mixed picture. And then there's still a question about, are there other types of subtypes? Is there a spectrum? And we'll talk a little bit about genetics and Parkinson's, but what about the genetic subtypes of Parkinson's? So this is kind of the best where we're at right now, but as far as kind of the subtypes, but still, I think more to see. And it is, Parkinson's is truly a spectrum. There's a saying in Parkinson's that if you know one person with Parkinson's disease, you know one person with Parkinson's disease. I mean, it's something that, with all those symptoms that I listed before, you may not have 80% of them ever in your disease. It's not a guarantee you're going to get all of them. So just something that's interesting and worth noting, and that everyone can be different. Everyone's different with their progression. Everyone's different with their symptoms and how they respond to meds. But this is so far the best way we can kind of subdivide patients. And we've been trying to do this because, especially in research with medications, we see that whenever we're looking at a medicine, there's always this subset of patients that respond really, really well to medications, and then so many others that either don't, or there's so much of a placebo effect that washes out the effects of the medicine. And so really learning how to subdivide these patients may be important to get more specific with their medication regimens and to get more medications approved. It may just be approved for one of these subtypes, but it's important to really try to subdivide these to see if we can find a medicine that's helpful for one of these groups. So as far as the young onset Parkinson's patients, the majority of these patients, you're going to really see some kind of genetic abnormality in them. About a third of them have a specific genetic mutation called the PARK2 genetic mutation. Again, we'll talk a little bit about genes and Parkinson's a little bit later, but these tend to be slower progression. So the earlier you are when you develop Parkinson's, the slower the progression usually. The older you are, so the reverse is also true. So the older you are, usually a faster progression. Again, obviously that's not true for everyone, but that's what we more or less see more of the time. They tend to have a lot more, like I said, dystonia is a kind of an abnormal muscle spasm, kind of muscle posturing of different parts of your body. They can have it of the hand, toe curling, so involvement of their feet. Some people have what we call cervical dystonia. It's kind of a abnormal kind of posturing of your neck, sometimes causing a head tremor. And they tend to have a lot of complications with levodopa, which is the mainstay of therapy for Parkinson's patients, or carbidopa-levodopa or Sinemet. What really can be seen with this is a lot earlier onset of dyskinesias, or kind of that abnormal kind of dance-like movements that you see kind of Michael J. Fox. They can have a lot of problems with what we call off times, where the medicine doesn't last that long. So they tend to be the ones that you need to pursue things like deep brain stimulation surgery earlier, Duopa pump earlier, things like that. So as far as the late onset Parkinson's patient, like I said, the reverse is true, where these are usually more rapid progressing patients. They tend to be more of the postural instability gait disturbance or akinetic rigid subtype over the tremor dominant subtypes. As far as, we'll talk again a little bit later about aging and Parkinsonism, but these patients have other issues, right? Other comorbidities that make them look like their Parkinson's is worse, or that they have Parkinson's to begin with. Arthritis will make you slow and stiff, obviously, and we'll talk about age, and then just decreased activities, other comorbidities that, when you have Parkinson's disease, when there are other things going on medically, whether it's issues with your heart, lungs, kidneys, whatever, they will translate to worsening Parkinson's symptoms. So a lot of times, kind of just as an aside, we'll see, Parkinson's patients will call me saying, I'm worse all of a sudden. That's usually never from Parkinson's, right? Their Parkinson's symptoms may have gotten worse abruptly, but that's usually a red herring for something else going on. So I always kind of bounce them back to their primary doctor or urgent care center, do a full workup, find out what else is going on, because it's not just the Parkinson's was, going along and all of a sudden they just worsen. That's usually not the case. And we don't want it to be the case either, because there's not much we can do about that. We want to find other things that hopefully we can fix, like a UTI, antibiotics, they bounce back and get better. So tremor dominant Parkinson's, these are definitely slower progressing Parkinson's. They tend to have also comorbid essential tremor. So essential tremor being more of a tremor with action, like you're trying to hold something or write. They tend to have more postural tremor. If they're keeping your hand in the air versus a resting tremor, that's essential tremor. So they tend to have a mixed tremor. These are there is in existence kind of a subtype of this where you really only see a very, 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 very slow progressing tremor. They do well for years, if not decades. They almost look like you're questioning the diagnosis because they look so good. So it's funny because whenever you see patients and they say it's a good thing I don't have the tremor, you kind of want the tremor because the tremor is usually a good sign that you're going to have a slower progressing Parkinson's. Tremors can be stubborn to medication, so they can be difficult to treat, or they are treated extraordinarily well with levodopa. So it's like one or the other. They tend to be a little bit harder to treat more of the time with most of the medications. So going back to videos, just kind of showing what a tremor predominant may look like. These are a couple patients here. So again, you just have the kind of the resting tremor here. And what will be interesting with these patients is you'll see kind of this re-emergent tremor where they hold their hands up. And at first, you don't see any tremor, and then there becomes this kind of emerging out of rest, per se, a resting position, that they have the tremor again. And again, same idea, actually even the same side. They both have a kind of asymmetric resting tremor, more of that right hand, obviously. Then you'll see, he'll kind of hold his hands up, and again, they'll look still. Now, this is not always the case, but this is pretty specific for Parkinson's too, where they have this kind of re-emergent tremor out of a resting kind of posture. And then the postural instability, gait disturbance or PIGID. So again, faster progression, more of the slowness, stiffness, like I mentioned before. We used to call this the akinetic rigid subtype. Much more risk factors for depression and dementia. So just in general, just a kind of a worse disease. Again, going back to the videos, just to show you kind of what this gait may look like with these types of subtype Parkinson's. This almost looks like this gentleman had a stroke, right? He's not really moving that one arm, kind of have it flexed to his side, but actually he has Parkinson's, and that arm is just really stiff, and kind of in that almost a dystonic posture a little bit there. And just a word about Parkinson's versus Lewy body dementia, because this comes up a lot, whether you're talking to patients sometimes or physicians. They are two separate, distinct diseases. We'll talk about the similarities and differences. They both may have early mild cognitive impairment. So there was an update in the diagnosis of Parkinson's disease where usually if you had early mild cognitive impairment or early dementia, it was not thought to be Parkinson's. It was always thought to be Lewy body. We know that this is actually not the case, that even Parkinson's patients can have early, and when we say early, like even within the first year, is what we're saying, dementia and cognitive issues. They both involve accumulation of alpha-synuclein in these bodies called Lewy bodies. So they both technically have Lewy bodies. And so Lewy body is just this abnormally formed protein that accumulates, or called alpha-synuclein, that accumulates within these kind of hollow shell bodies in your brain and in cells of your brain. So the differences come in where we find these Lewy bodies. So Lewy body dementia is more seen in the limbic and neocortical areas, and Parkinson's usually first in the brainstem. And I'll kind of show you a picture of the Brooke theory of how Parkinson's kind of progresses through your body, and give you a nice description of why it may be seen in the brainstem first, and then later in limbic and neocortical regions. So to be honest, you can have two patients and they look the exact same, right? Same symptoms, but one may have Parkinson's and one may have Lewy body, and really it comes to the historical view of how they progressed over time. So Lewy body is much more faster progression, much earlier problems with gait and balance impairment, early autonomic dysfunction, and then again early dementia, but that's not necessarily sets them apart. They have these periods of time during the day where their attention and arousal will just change. And it's true that, even with Parkinson's patients, they can get sleepy during the day, but these are like abrupt, they go from like sleeping to awake to out of it again, and just kind of fluctuating throughout the day. Their Parkinsonism motor symptoms affects usually both sides of the body symmetrically, versus Parkinson's is usually almost always asymmetric involvement. And then this is the true kind of historical feature that you really want to kind of figure out when you're trying to tell a patient if they have Parkinson's or Lewy body, is that early on they should have the psychosis, right? So within the first year of their Parkinsonism motor symptoms, they need either visual hallucinations, less likely auditory, but usually visual, delusions, or kind of ideas that are not based in reality, like the mailman stealing my mail, or unfortunately, a common one is called delusional jealousy, where you think your partner or your spouse of 50 years have started to cheat on you. And then illusions are things that you see, they're real objects that are there, but you perceive them as either moving or something different. And really, it comes down to, if we're trying to diagnose this accurately. Unfortunately, it's done post-mortem, just neuropathology wise. Up before then, it's just a kind of a clinical presentation. Again, if you're someone who have had Parkinsonism for 10, 15 years and now develop psychosis, you just have Parkinson's disease with psychosis. If you're a 65-year-old who 6 months ago developed tremor and then is having hallucinations, that's more Lewy body. So this is just an example of what we call a DAT scan, or technically this is a PET scan, but they look very similar. This is one of the few tests that we have, if anything at all. This is the only test that we have that can differentiate Parkinson's disease and what we call the 4 Parkinsonian conditions. So there's kind of 5 Parkinsonian conditions that are within the same family. They include similar processes as far as what happens to the brain and to the dopamine system. And so you have Parkinson's disease, Lewy body dementia, PSP, or progressive supranuclear palsy, MSA, or multiple system atrophy, and then cortical basal degeneration syndrome, or CBS. And so if the DAT scan is abnormal, and you can see on the left kind of this normal lighting up of the dopamine receptors and what we call the basal ganglia area of the brain, and so there's kind of a really nice density there in the red. And then you can see on the right side there's this asymmetry, green being less dense for these dopamine receptors. This would be positive for, again, one of the 5. So there is no test to absolutely differentiate between the 5 Parkinsonian conditions, at least not yet. And so we sometimes rely on this to help figure out, is it one of the 5 or is it something else? And then just in the bottom here, gross pathology of the substantia nigra, or black substance, is where it gets its name from. And you can see that there's just less of this black substance or the cells that produce the dopamine. I alluded to before that there's many other things that can cause Parkinsonism. Like I said, medications can do it, usually dopamine blocking medications. And then we'll talk about some of the other exposures that can contribute to Parkinsonism. Other things, like I said, strokes, Parkinsonism can appear in other kind of diseases. head injuries, we'll talk about a little bit. There's normal pressure hydrocephalus that can have Parkinsonism with it. And then the real thing here is the normal aging, and this is what I was kind of referring to before. There was actually a study, a 1996 New England Journal of Medicine study that showed that in actually a large population, they tested thousands of individuals in certain age groups, and these were people who definitively did not meet the criteria for Parkinson's disease, but they still were evaluated with the typical what we call the Parkinson's kind of rating scale or motor rating scale, and were found that the older you get, the more Parkinsonian you look. Like I said before, the slower you get, stiffer you get for a number of reasons. Obviously, like I mentioned before, you have arthritis, you have heart issues, you're maybe more sedentary, and so a lot of these starts playing a role on your balance. You maybe have diabetes, neuropathy. So I get a lot of my referrals for older patients who have Parkinsonism, and the whole question is this just normal aging, or sometimes what we call multifactorial Parkinsonism, or is this the actual disease of Parkinson's disease? So going to kind of Parkinson's etiologies, there we'll talk a little bit about what kind of exposures, environmental exposures there are. We'll talk a little bit about the gut theory behind Parkinson's, and then genetics. So environment, job exposure is a big one. So what do we see as far as what those could be? So one of the main ones, one of the biggest known ones are farming chemicals, pesticides. Exposures to them is a huge risk factor, and we'll talk about numbers in a little bit, but definitely one of the things that we see more commonly. If you're a welder dealing with welding chemicals, also a major risk factor for Parkinson's. If you're a chemist or work in chemical factories, definitely a risk factor for that. If you're actually in dry cleaning, there are some dry cleaning chemicals that can put you at a higher risk of that. Cabinetry is interesting, but cabinet makers deal with certain chemicals sometimes that can make them at a higher risk of it. And then electricians also can be exposed to certain chemicals within their occupation to raise that. Not usually as common, but definitely can be seen. So what are some other environmental issues? So these pictures are kind of oriented in size based off our data that we have, reflecting their impact. So actually, smoking, and this is not fully elicited yet as far as why this is, but smoking will lessen your risk of Parkinson's disease. Now, we know that smoking after developing Parkinson's will worsen your disease, so we don't really obviously recommend that to anyone, but it's just something interesting that even as we try to duplicate these research studies on risk factors for developing Parkinson's or protecting you from Parkinson's, smoking is something that always comes up, even in a recent article within the past few months, that, yep, it is protective against Parkinson's. It may cause you to die from other things earlier, but it is protective, and we don't know why that is. So caffeine, so if for those who drink a cup of coffee a day, you have a less chance of Parkinson's. So it's also protective, also something that we don't know why that is yet. Well water, exposure to well water, and again, I'll show you some data a little bit, but well water may increase your risk of Parkinson's. I've been working with the epidemiology group here at Christiana, trying to better evaluate this in our home state. It's a hard thing to do, obviously, a hard thing to go back on, and we'll talk about kind of limitations to doing research on these different risk exposures in the environment. We know that Parkinson's disease is mainly an environmental kind of phenomenon, meaning in genetics, there's only about 10 to 15% of Parkinson's patients who clearly have a genetic link that you could maybe point back to as far as why they develop Parkinson's. But for the majority of others, it's usually some kind of environmental risk factor. most of them that we don't know of yet as far as what kind of environmental risk factor, because you can look through these slides and say, well, I don't really have any of these risk factors. Why did I get it? And that's still the ultimate question. And then ultimately, there's this idea of maybe a combined environmental and genetic kind of makeup of why you may develop Parkinson's. That yes, not all farmers are going to develop Parkinson's disease, but is it that certain people who are in farming have a genetic abnormality that makes them more prone to developing that in the right environmental conditions? So there was a big interest study on thinking that dairy led to an increased risk of Parkinson's, but subsequent research trials have not really proved this or really shown that this is necessarily the case. There may be a slight link to it, but it's not enough to really have that as any kind of recommendation, going forward. And then there is also there was some studies looking into statins and Parkinson's risk. There was initially some small studies showing that statin medications may increase the risk of Parkinson's, and then there was actually some that said it was neuroprotective against Parkinson's. So I think because of just the kind of competing, conclusions that we just kind of, right now we don't really have any good evidence saying either one way or the other. NSAIDs potentially are protective against Parkinson's. It's a little bit unclear. The studies are not that great, regarding that. Also, uric acid, and this is just a picture of gout, but uric acid that plays a role in developing gout has been shown to maybe be neuroprotective with Parkinson's. That it actually turns out that if you have issues with gout, that you're probably not going to have Parkinson's as well. And so there has even been trials involving medications to boost your uric acid to see if that is helpful for Parkinson's, but they unfortunately didn't pan out either. So this is kind of some of the data that I want to show you. This is I know it's a little bit hard to see. Maybe I'll go zoom up a little bit here. So this is from a 2014 study published, a meta-analysis in Neurology, kind of just showing maybe some of the odds risk scores for certain exposures and Parkinson's disease. And you can see that, unfortunately, a lot of the p-values were just not great there. But even not accounting that, you could look down this list, and really the odds ratios are not that impressive for increasing the risks. There are some that are more significant, like paraquat, we know can definitely raise the risk greatly for Parkinson's. And so just wanted to show you that, a lot of these odds ratios are mostly, in the ones. And again, you have to look at the p-value, but and this is what I was saying before about well water drinking, maybe a slight increased risk that was statistically significant there. But so there are some better studies, within this meta-analysis that maybe show that some of these are a little bit higher associated and significant with Parkinson's, but it's not like a definitive thing, right? That, if you're exposed to this, you're going to develop Parkinson's. So it's a little bit about head injuries. So obviously everyone thinks about Muhammad Ali getting Parkinson's. Obviously he was a boxer, so he sustained multiple head injuries. There has been some, awareness that head injuries can lead to a higher risk of Parkinson's. Usually the head injury needs to be at least a mild to moderate severity. So you're definitely talking about concussions here. It's potentially, when you have this risk, it should be years, if not decades before. So it's not like something where you got a concussion last year and you're developing Parkinson's right now. It's usually the inflammation that goes with head injuries and maybe the development of Lewy bodies from that is something that's not going to happen for some time. And we know this from the CTE or chronic traumatic encephalopathy studies that have been done in football players and things like that, that usually you need years before that stuff really develops. Obviously the more head injuries you have, the higher risk you have. So it truly is not really clear if you could have just had one bad head injury again when you were younger. Will that lead to Parkinson's? We don't know that, but we do know obviously the more you have, so boxing, football definitely makes you at a higher risk of Parkinson's. If you're over 55 with the head injury, it definitely increases the risk within a 5-year time span of having Parkinson's. So later in life, head injuries your brain may not be able to deal with that kind of inflammation as great. Not to mention that the kind of disposal system of alpha-synuclein that we all have in our brains are probably not as functioning as well, or because of the head injury do not function as well, and that's why you get this accumulation, because we actually do have this system where we eliminate abnormally folded proteins like alpha-synuclein, but that system is dysfunctional in Parkinson's. And again, we've seen in animal models that with head injuries, you do have this accumulation of alpha-synuclein and just more inflammation. So what I used to call the BRAC, but I think it's actually pronounced the Brook theory, has been around for some time. This is the idea of how Parkinson's and where Parkinson's may start. So like I mentioned before, some of the prodromal factors or symptoms of Parkinson's include constipation. So is there something there that really makes us think that Parkinson's develops from the gut? And this is where the gut theory comes from. So what Brook did was he took the pathology of Parkinson's disease patients, and he really tried to find, in different stages, and tried to find where did we see alpha-synuclein developing or Lewy bodies developing. And what he found was that earlier Parkinson's patients tended to have only this accumulation in the brainstem, whereas as you progressed, the accumulation got higher up in the brainstem, and it started to involve kind of the thalamic area, and then eventually the cortex later on, and then associated with cognitive impairment. So, is this something that lower down it's accumulating? We'll talk a little bit later in the next slide about more of the gut theory, but that's kind of where we're trying to look. Okay, maybe it's not just something that sporadically starts happening to the substantia nigra, but maybe it's somewhere else. There is also this kind of little redness right here is where your sense of smell comes from. That's the cranial nerve that it comes from, and so obviously a loss of sense of smell is something that will put you at risk of thinking that this is going to be Parkinson's down the road or already. And so is it something that may start there, or in general your mucosal areas? So obviously your nose, your mouth, intestines, as a potential risk factor for that. So, and again, with some of these exposures, especially the job exposures that I discussed, a lot of that comes from potentially inhaling some of these chemicals. So exposing the nose and the lungs. And so just more to the gut theory, there's a couple, things about this, and we'll talk about this in the next slide. But, there's one thought that actually the alpha-synuclein travels, these aggregates travel up the vagus nerve because in some studies showing kind of pathology of the vagus nerve, actually in living people after it was transected for certain conditions, they actually found that in the efferent vagal innervation kind of leading up to the brain that there was alpha-synuclein and Lewy bodies within it, but it wasn't found in kind of the innervations going away, the afferent vagal innervations. So that was something interesting. We know that in certain pathologies of the intestines that we have seen Lewy bodies within there, that this may be a good way that alpha-synuclein does propagate up, because it's not necessarily it's not like the blood-brain barrier. It's much looser than that, obviously, when it comes to abnormal proteins, and we're talking about involvement of the microbiome within the gut playing a role in maybe loosening up this kind of cellular wall of the lumen that may allow for abnormal proteins or exposures to get through to really start affecting, again, starting at your gut, alpha-synuclein deposition and then kind of going up from there. And again, potentially using the vagus nerve as kind of a route up to the brain. Now, over time, this is still a theory, even though it's been getting a little bit more press recently. This has been a theory that's been going on for at least 20 years in our awareness that the problem is that there are studies that are both for this gut theory and then actually not insignificant ones that are against it. So it sounds great, and it sounds like this potentially could be something that makes sense. Again, a lot of the pathology that we've seen, we found alpha-synuclein within the gut and within the vagus nerve, and so this is in early Parkinson's patients. So it's not like they're Parkinson's patients that just have alpha-synuclein everywhere. We've seen in animal models that this might be a good way to actually cause Parkinson's by introducing kind of alpha-synuclein into their gut. But having said that, there have been larger studies trying to replicate this, and really it's not really necessarily seen. And when you start looking at more and more people, this isn't necessarily what we see. And so the question is, is this again maybe a subtype of Parkinson's that do develop it from their gut? Maybe others do develop it from their nasal passages. So, it's just that whenever we try to replicate looking specifically at the gut as the cause, just hasn't really panned out. So kind of a mention about genetics. There's plenty of genes that we're aware of nowadays, and this is expanding exponentially. As especially there's this huge kind of multi-center trial right now going on between University of Texas, University of Maryland, and I believe also Michael J. Fox Foundation that are looking at thousands upon thousands of Parkinson's patients' genomes to really find the smaller risk factors, again, that may not cause Parkinson's, but put them at a higher risk of developing it. So just to kind of orient you here, the genes in blue are all dominant genes. Yellow are recessively inherited and causing a Parkinson's. And then all in green are just ones that, again, increase your risk of developing Parkinson's. And the size of the circles is how common they are within the Parkinson's population. And then this is just, again, how common they are in general, and then how highly associated they are with causing Parkinson's. So, for example, LRRK2 is one of the more common genes that definitively causes Parkinson's in a lot of patients, but in the overall population is not very common. And then all of these kind of risk loci are common in the population, but tend to have just a low associated risk of developing Parkinson's, and then you see that. So it's kind of painting a picture of what we have now with our known genetics abnormalities with Parkinson's. And then I kind of alluded to this before, but this is the idea that people who are younger in age definitely are, if they have Parkinson's, it's going to be from some genetic background or abnormality, versus later in life, probably not genetically related, but more likely related to other environmental factors and things like that. Again, kind of illustrating the same thing where, this idea that over time you're more exposed to environmental toxins, so it would make sense that developing later in life, it's more likely related to some kind of environmental exposure than it is genetics, some kind of genetic abnormality that you may have. So ultimately, really learning more about not only the subtypes, but the etiologies. It just makes sense, unfortunately, that we are where we are in our knowledge or where we're not, because, we still don't know when Parkinson's starts. We know that when people develop the motor symptoms of Parkinson's, that it's been going on for years, if not decades before. And so we try to find the prodromal symptoms, like I mentioned before, with REM sleep behavioral disorder or smelling issues. I mean, we're trying to find it earlier on. Some people think that the depression and anxiety, as obviously not as specific as that, can be one of the early factors. So it's just something that we struggle with. again, what kind of exposure time frame do they need? So I mentioned before that we utilizing the majority of the epidemiology department at Christiana really was trying to look at if you live in Delaware, what's your likelihood in different areas of Delaware developing Parkinson's, but not knowing how long people have been living in their house has been an issue, because if you just moved to Delaware and you develop Parkinson's, obviously you didn't get it from living in Delaware, so we don't know the exposure time frame. Again, there's this genetic interplay that kind of complicates the situation a little bit. There's, again, as I mentioned before, the spectrum of the disease, right? Not everyone looks the same. We know about subtypes, or we think we know about subtypes, and we're probably still going to find more subtypes that exist. And not all subtypes are created equally, obviously. And then, it's still, not a very common disorder, right? In a population of 1 million people, like I said, there's probably only 3,500 or so, 3,400 people with Parkinson's, and probably a majority of them are ones that kind of integrated from other states. So just to kind of give you kind of the future of Parkinson's, so that it is kind of outlook is good. These are all the therapies and medications that we've developed over the past 5 years till now. So and even within the past few weeks, we had a new medicine. So at least we're developing more things for symptom control. We still don't have a lot or to be honest, anything to control the disease progression. It's really just exercise still. But hopefully within the next 3 to 5 years, we'll have our first disease-modifying agents, crossing our fingers. But really the future also involves finding better biomarkers, not only for diagnosis, but to follow people over time, progression, prognosis. We don't really have any good ways of doing that now. New leave-it open delivery systems, we know that the stomach gets in the way of the way the medications work. And so finding out new ways to kind of administer dopamine into the brain. Again, true disease-modifying agents, like I said, other therapies like the MRI-guided focused ultrasound or something that's been new for Parkinson's, and then better meds for depression, dementia as well. So that's all I got. Thank you for your time, and if you have any questions, I'd be more than happy to answer them.
Thank you very much, Dr. Martello. Any question for Dr. Martello? Well, I have a question, actually. So there seems to be, it's a little daunting, all the symptoms and syndromes that seem to be present, within Parkinson, that are present. So in practice, how do you make a diagnosis?
Yeah, so there is technically criteria that was released, even new criteria from the Movement Disorder Society, that really, in general, you need the classic bradykinesia. And again, people can be slow for different reasons, but it's that decremental movements in their motions, kind of the hesitation. So you need that, plus the cogwheel rigidity or the resting tremor. And then there's a lot of other supportive criteria, red flags, absolute exclusional criteria that we use as well. And unfortunately, a lot of these things, as you're kind of alluding to, can be subtle. And so that tends to be why, and this is borne out in research, not kind of tooting the movement disorder horn here, but unless you see Parkinson's like I do, I see 8 to 10 a day. It's hard to develop that nuanced approach and kind of awareness of subtleties within their movements, and it's all about the way you approach patients. You walk in my room, I'm looking you up and down every single movement that you're doing from start to finish. So it's just a familiarity with seeing the spectrum of types of movements.
So do you use MRI or any imaging in practice to establish the diagnosis, or this is not part of the diagnosis?
Yeah, so for the most part, I don't. The only thing that I usually might get is the DAT scan, but it's not something I get commonly either, because most patients are pretty classic and obvious for when they have Parkinson's. If there are red flags or atypical features of their disease, that will be my first step, because either if the DAT scan is abnormal, that kind of stops all the workup, and yep, you got one of the 5, like I said, Parkinsonian conditions. But if it's normal, then that kind of directs us to much more testing, MRIs, like you're saying, lumbar punctures, things like that. And I don't see the chat feature, so I'm not sure if there's anyone chatting any questions.
Don't think there is anything in the chat.
No, I don't.
Lisa, do you see?
No, I don't.
Right. Okay, well, if there are no other questions, well, thank you so much. This was so informative. I learned a lot.
Anytime.
Thank you
Thanks
so
for
much.
having me.
Thanks again. Have a great weekend, everyone.
All right.